Okay, so we're going to place the central line today. I've already looked in the patient's chart. They don't have any contraindications to placing a central line, no abnormal anatomy, no infection at the site. All of our consents are signed. Their PT and their INR and platelet count are normal. And we're going to also make sure that they don't have any allergies, which they don't. We'll make sure that our ECG leads are on, our pulse ox is on, everything is audible, and then my hands are washed so we can go ahead and look at our anatomy. Using the ultrasound, I'm going to check the internal jugular vein and artery, check for compressibility, identify which is which, make sure that the artery isn't immediately posterior to the vein. If I need to, I can adjust the head and put the patient in a 10 to 15 degree Trendelenburg position to get better exposure. So I have identified all of my landmarks, and I'm going to go ahead and get my hairnet and mask on. Okay, so we'll go ahead and get our patient prepped with the CHG while we're putting the rest of our gown and gloves on. So prepping with CHG, we're going to allow that to dry for 3 minutes. In order to see the sterile technique putting the gloves on, I'm going to put them on the patient's chest. Okay. I'll get someone to tie up my gown for me. And we'll go ahead, now that the patient's CH3 is all dry, we'll go ahead and get the patient draped. Making sure that we don't break sterility. It's a little bit challenging to place this because it's been unfolded a couple times. But we're in a good spot. We have exposure here to where we're trying to access. And we'll go ahead and have our assistant hand us the ultrasound back with the sterile probe cover on it. So we're looking again. Okay. I like what I see still. We can keep it sterile, put it down on here. I'm going to make sure my kit is all assembled. My distal port is uncapped but not flushed. And our proximal port is flushed. Our guide wire is ready and available. And we will go ahead and take a look. We're going to insert our needle to facing the ipsilateral nipple. And so we'll have right in the middle of our ultrasound. All right. I'm poking and maintaining negative aspiration as I insert until I get blood back. At this time, I'm getting blood return, so I'm going to go ahead and thread my catheter, remove my needle. I have venous blood return, and I will go ahead and insert my guide wire, watching for any sort of ectopy and making sure there's no resistance whenever I'm inserting. Okay, now we're in a good spot. We've inserted about 12 to 15 centimeters, and we'll take a longitudinal picture for the chart using our ultrasound. All right, at this time, we're gonna remove our maintain control of our guide wire, and we'll remove our catheter, keeping everything sterile. Catheter is off. We'll use our scalpel to cut a little hole for our dilator, and we'll be careful not to cut our guide wire at all. We'll use our dilator at this time. There we go. Dilator is inserted 2 to 3 centimeters. All right, we'll remove our dilator. And advance our catheter over the guide wire. All right. We're going to insert our catheter 12 to 17 centimeters. Again, making sure that there's no ectopy noted. Once we get to where we need to be, we're going to withdraw our guide wire. We're going to make sure that we still have blood return from our distal port, and we're going to check our proximal port, and we still have blood flow. We'll flush both of our ports, and then I'm going to suture the catheter in place. That's where we want it, and place a central line dressing with a bio patch, and then we will go ahead and make sure that we have a chest x-ray ordered to verify placement.